It's late in the day. I'm going to keep this pretty simple with some pictures, just to take us on a few patient journeys through the lens of their imaging and their journey over a couple of years. And I want these cases to try and illustrate the incredible heterogeneity, as you all know, of this disease, neuroendocrine tumour, in terms of its distribution, the behaviour of the disease, the response to different treatments. And I just want to show how functional imaging can be used to guide the sequencing of the available therapies that we have. Of course, SSA is a standard, but how and when do we use lutate, chemo, targeted therapies, liver-directed therapies? And of course, our tools to offer from the nuclear medicine side are gallium dotatate imaging with the reflecting somatostatin receptor, expression on these tumours and therefore differentiation of the tumour, and as well as FDG imaging, which really more reflects de-differentiated higher grade clones of the disease. This first patient, 67-year-old woman with mid-gut metastatic neuroendocrine tumour. Her story begins in 2004, at which time she had a major liver resection. Recurrent disease in the liver 7 years later, some TACE in 2014, and then we see her. So here she is in 2014. I'm really hoping this mouse will work for me. Yeah. And the disease she's got hepatic disease in the liver, upper abdominal nodal disease, and a paraesophageal node here. So looking at her there, she's quite well. We don't look at her for nearly a year. Things are very similar. And on we go, just annual surveillance or 6 monthly just to check. And you can see that over this time there's been a slight increase in the size of a couple of the sites of the disease in the liver, but really over a nearly 4-year period, she's got very stable disease, minimally progressive, and she was managed on SSA with no other intervention. This case is similar in that a patient over a 5-year period demonstrated a completely stable course with her really high volume disease. The majority of this disease is in bone, liver, upper abdominal nodes. And if you saw this patient in 2013, you'd think, really, there can't be long with this. This looks terrible. But in fact, she was managed just with SSA, and over up to imaging just as recently as February this year, that disease is completely static. So she doesn't need anything else. SSA is holding her disease, and we can just watch her. Clinical features aside, of course, if there's functional syndrome that's changing and getting worse, that's another element altogether. But just in terms of this imaging component, this is the message that we can give. This patient, another one with a mid-gut net, was diagnosed with mid-gut net when she was found to have a mesenteric mass, and she was started on SSA. This is back in June 2016. We looked at her quite quickly just to check how her disease was moving, really quite static. What she's got is upper abdominal nodal disease and a small volume bony metastases. What we can see over time with this patient is that she's actually developing hepatic metastases slowly and a few more bony metastases. So here we've got someone with a different tempo of disease, albeit a slow tempo, but she's starting to change in her behaviour. So do we want to stop and think what we would do?
Yeah, probably a good opportunity to ask a question here. Shell, we're only presenting nuclear imaging, but sometimes these patients often will have had an interval CT along the way. I think this lady, I don't think the liver mets were visible on CT imaging, so we've learned things we wouldn't have otherwise known. So the question is, should that be impetus to recommend therapy in this case?
No, actually, I mean, she is already on somatostatin analog, and what we will do in such a case is increase the dose, shorten the interval, to see if that can prevent further proliferation. If not, then we are in our center we also add interferon sometimes, but more often we now go for lutate if the increase in dose is not working.
Yeah, but Shell, there's no data on the outcome of increasing the dose. Not yet.
No data from randomized trials, but there is a lot of eminence-based observations that by increasing the dose we can definitely have an impact on continuous growth. And now there are ongoing studies to show the high dose treatment.
And do you monitor with nuclear imaging or CT? Because I worry that the imaging is so good with picking up asymptomatic disease, but you have to tell the patients the result of the scan. And as soon as you tell the patient that there are new things, the bias is towards starting treatment.
But usually, as a standard in most centers, I think we monitor with CT scans or MRI. And then we do not as often the radio nuclear as you are doing at the moment.
Can I ask you, Gabby, in this patient, Bill next, just on basis of radiologic imaging alone, let's say asymptomatic, what would be the feeling in your centre?
Well, in this case, it's 18 months with the volume of disease being really quite slow. We would add in, we don't have quite the access to functional imaging, so we would be using anatomical imaging. And if this patient's got a chromogranin A, we do like our chromogranin A, we use that and the doubling time, which I think very useful. I think we have to continue to use that as a very useful marker. But if this patient's asymptomatic, I just continue with an analogue. And yes, we do decrease the interval and maximise the dose.
So I'll be the devil's advocate and put to the panel that the NETA-1 study has now shown that patients in this situation have improved overall survival if they're treated with PRRT rather than increased dose SSA. And should that study change our practice in this situation, even though the patient is clinically well and asymptomatic?
My comment is that you are still dealing with low volume disease, and therefore I think I would stay with cold somatostatin. And also, if you look at the recent overall survival data from the NETA-1 study, you have really a long overall median survival of 32 months with cold somatostatin, high dose, 60 milligram.
This was actually to Professor Oberg. Now that you've got the NET test, can that help us decide?
Actually, this is a case where you can use the NET test and see if you have a real progression. So, but I mean, before going to an expensive NET test, maybe I would try the dose increase first, and then if that is not working, then I go for a NET test.
These doses is also quite expensive, but someone else pays.
All right, so on to the next case, which is a little easier in some respects. This lady has a pancreatic neuroendocrine tumour with good going hepatic metastases and a rib lesion. Sorry, wrong way. We had a look at her FDG and she only had a little bit of avidity of the pancreatic lesion and not much in the liver. Looking at her after nearly 6 months, things were okay. Looking again another 6-8 months later and her disease is on the move. The hepatic metastatic burden has increased, rib lesion much more obvious, the pancreatic lesion getting bigger. So in this patient, the decision by the MDT was to start lutate. It's clearly progressive and becoming more voluminous, and I think in some respects that's easier. This next patient is another patient with metastatic pancreatic neuroendocrine tumour. She at diagnosis had a pancreatic primary, some local nodes and hepatic metastases. Quite a lot of this disease was significantly FDG avid and in a concordant fashion, no discordant disease. She was trialled on SSA to start with and checked quite quickly to see how she was going, and it was clear that she had very rapidly progressive disease. This is quite a different scenario to the previous patients. Progression of the pancreatic disease, the liver disease, evident particularly on DOTA, but also FDG, and there was no discordance. So she went on to have lutate therapy. Sorry, I'm losing my mouse. And we, for a period of time, used to look at patients after 2 cycles to see how they're going. And so a couple of the patients will have that. So we can see her disease regressing and stabilising there in response to lutate, and also a normalisation in the liver of those FDG avid disease. So where there was concordance, good localised radiotherapy to the lesions from the lutate therapy resulted in good control of her disease, both FDG and dotatate avid disease. And you just call me when you want to stop.
Yeah, well, I might ask just correct
There is a new lesion coming up in the lung.
It's that was a little inflammatory nodule. Yeah, sorry, I didn't capture a thing.
We obviously moved fast in this case and said we went on to our lutate protocol. It's part of the Cancer Institute funded observational study with capecitabine. So consequently, the patient actually is getting some chemotherapy with it. Shall, in the absence of access, because in Europe, lutate wouldn't be offered in this circumstance.
I must say that in such a patient with both FDG positive and gallium positive lesions, I think most clinicians would consider to go for a more aggressive treatment, thinking that this is an aggressive clone that you have, and they go for chemo or everolimus, the targeted agents.
This lady's Ki-67 was 15%, and I presume we probably did discuss with the option of the trial.
Yes, I think so.
Which is randomised to Cap-10 versus Cap-10 lutate, but I think she didn't want to go on.
I just want to put it out there. I would rebiopsy her. I don't think she's 15%. I don't know what the SUVs were. That rate of change in 4 months from August to September is of a huge concern, and I would be interested to see what the SUV was, but I would be thinking if she was well differentiated, she'd still be a net that looks like a 20 to 50%, and that would have pushed us to systemic chemotherapy first, in whatever combination, be it everolimus or Cap-10, rather than PRRT and chemo. Yeah.
So we have a patient who's in hospital at the moment, a similar picture, and I don't know, is Tim Short still here? Just left. Okay, so I go and ask the radiologist where you can biopsy somewhere where the Ki-67 goes up. That's what I ask him. And then after a lot of umming and ahhing, they go somewhere and then it comes back 5%. I've had 2 patients like that.
Did you use your FDG as
Yeah, because like when they put the needle in, there is no guarantee that it ends up where the FDG scan shows high uptake, because things move. So I'm not saying you shouldn't. That's what I would do. But it's also unreliable. So if it comes back lower, does that mean the disease is less aggressive? No.
No, if you were using, if your algorithm was that you were still considering this at 15% and you didn't feel that they were eligible for one of the many trials now. I mean, LUCAT will be one, there'll be several. That's all I'm advocating. Certainly needed systemic therapy. That's a nasty clone that you've managed to stabilise, but concordance is good, but it's a high grade and systemic aggressive therapy to decrease the volume before you give other systemic therapy.
So what is happening after September 17 with this patient?
She's actually got recurrence of some bony mets, so I didn't continue on with all of the imaging there. You'll see other cases where things have progressed after lutate, but I didn't capture all of them.
She's still not receiving any chemo, or
I'm not sure, actually. I have to say, I didn't. I just captured it from a previous set of MDT I had.
She was scanned on Friday.
Yes, that'll be why I didn't get it. We'll be seeing her on Tuesday.
No, I think with systemic disease, I think she is, but we haven't followed it up for the presence of the case.
Yeah.
But can't you say the lutate's worked?
Well, it has. So one of the things I wanted to make a point of, and we've seen this before, is one of the earliest observations was the FDG avid disease goes away very quickly with lutate. And we've had a number of patients with this grade 2 disease, with FDG positive disease, who were part of our earliest lutate experience 7 years ago. And they get rapid resolution of symptoms with bone pain and improvement in the FDG, whereas the gallium just stays there in the background. And there's a series of patients we have, and it'll be part of something that we'll write up, where we've observed these patients subsequently go on to chemotherapy when they've actually had even more aggressive disease. So whilst this looks aggressive to you here, I guess our experience the last 7 years is we've seen worse, and we thought that her trajectory looked worse radiologically than clinically.
This next patient, also pancreatic neuroendocrine tumour, she had similarly liver metastases with some FDG avidity, a pancreatic primary lesion which was a bit more FDG avid than DOTA at diagnosis. And quite quickly she progressed, as we'd expect. It should say chemo here as well. She was a control nets patient who went on the chemotherapy arm first, and we can certainly see through this period, where's my mouse, through this period that she had some control of her disease and normalisation of the FDG avidity. What's happened since then, just in January this year, she's had a resurgence of her dotatate avid disease. So she's gone on now to have lutate. We don't have any progress imaging just yet. So she has sequenced through chemotherapy and now to lutate.
Yeah, so the protocol allows crossover to lutate in the CAPTEM arm once they've progressed. So she does have interval standard radiologic imaging, and she had to fulfil progression on RESIST to actually cross over.
Have you got a follow-up FDG?
No, I don't. We don't, yeah.
Does anyone else from the audience have any questions around the progress of these cases so far? Anything you want to ask?
This next patient, grade 2, pancreatic neuroendocrine tumour with liver metastases. Bit of a busy slide, I'm sorry for that, but bear with me. This patient back in 2014 had liver disease looking like this, some peripancreatic nodes after resection. After completing 4 cycles of lutate, you can see good regression of the liver metastases. I don't have a prior FDG, but at this point it was negative. And over a good year, the disease was stable. At 12 months, the patient developed a lesion, a discordant single FDG avid lesion in segment 2-3. And the patient underwent some TACE and the lesion responded well. Here we are 6 months later and things are on the move again, a dotatate avid lesion, a little bit of FDG avidity emerging. Still getting a bit bigger and the FDG becoming a bit more obvious. There was no discordance. So the patient went on to have some lutate again, with good regression of that dotatate avid disease and resolution of the FDG. After a further 2 cycles of lutate, the dotatate avid disease looks all right, but she's emerged again to have discordant liver lesions. And in April, she had a further dose of TACE. We haven't yet seen her follow-up. So,
it's a he, I think.
He
had his lutate at Peter Mac, and then he came back up to us afterwards, and we've been following. So it's liver-only disease. So he's yet to have chemotherapy. I forget what, we haven't got his KR67. I think he's a grade 2.
Grade 2, yeah.
Net. So, but that's where we're heading next.
But at the moment, it was appropriate to have this local treatment to the liver, I think.
And I mean, it's interesting, if you attempted to guide therapy with CT, you'd have a tough time. Yeah. Because we've got a mixture of concordant disease that will respond to lutate, discordant disease that's not. And I think this imaging allows us to be a little bit individualised about what this patient needs.
I think this is a very important study you are showing now, the value of doing both gallium and FDG PET in the patient, guiding you for the right treatment. So this is good.
This next patient is a little simpler. She had an ampullary pancreatic primary excised as far back as 1983. Wasn't until 2006 that she got bone metastatic disease. And 2012 had some chemo, some lutate down in Melbourne in 2012, 13, or it must have been 13. So here we are with a scan showing widespread bony metastatic disease. And after lutate, she showed good regression of that disease. And that remained stable for some years. In fact, the disease slowly regressed even further without any further intervention. Halfway through last year, she showed clear progression, a new site of disease involving a node which she'd never had before, and resurgence of her bony disease. So she has undergone a further 4 cycles of lutate and will come up to her follow-up soon. So she's lutate, stability, and then a further
So
cycle
how
of
many
lutate.
cycles did she receive in the first round?
Four.
Four.
Four
Okay,
and
so
4.
total 8.
8. Over 5 years, yeah.
Also scanned on Friday.
Oh,
we'll
I
find
was
out
somewhere
soon
else on
enough.
Friday.
So the most we've done, I think, in one patient since 10, since we started about 6-7 years ago. Gabby?
We have a gentleman, we've just given him his 13th dose over many years. He has a insulinoma and he doesn't have an option. Otherwise he's stuck on a dextrose infusion. We're really at the pointy end. He's had chemo in between. It's incredible. He responds really well, except our interval now is reducing and it's now in terms of months, still several months, but he's got no hematological toxicity yet. We know that we will get to that point. But he's become resistant to, and he's had every other form of chemotherapy, systemic therapy, and he's just one of these really unusual. So I'd love some advice as to what we do next.
Is not on everolimus?
He's had everolimus.
Okay.
And would interferon work in that circumstance?
No, I don't think so, because usually they are too aggressive for that.
Would that be a patient in which intraarterial PRRT might be worth considering?
Sure, if someone with virus is nothing to do that.
Assuming they're intrahepatic.
Yeah, and it's actually astounding. He does not have high volume disease. It's just incredibly active and creates enough insulin that, I presume it's insulin, we've never really measured it, but we know that it becomes hypoglycemic and comatose unless he gets something.
If he's responded to lutate, why not cert?
There was a problem with him with cert. He's being evaluated for cert, and I think the problem is that he has it's his shunting. He's got shunting.
So
Which might be why it gets so symptomatic.
What type of chemo did he receive?
He has had, over time, he's had carboatropicide, which is what his oncologist has chosen to use.
And it didn't work.
It held him for a few months, yes.
Okay.
Yeah. He has had, I don't think he's had Sutent, and there's a reason for that. He's had everolimus. And then we salvage him, and at any one time, we've not given a retreatment of 4 doses. We tend to just give 2, maybe because we know we just need to keep them up our sleeve. So can I just ask, I know this is a 3-year gap on this one, Liz, but how often do you retreat with a full 4 cycles?
Really depends on the patient's scenario, how rapidly the disease is moving, I think. We've got someone who will be, has bad disease, responds, is held, and we might treat again. I don't think we're too concerned about coming back in within a year or a year and a half. Nick, would that be right?
It's certainly been ad hoc, but more often we've done just 2 than 4 in
Yeah.
second round.
If it's for disease control like that.
Is the kidney function and the bone marrow still good?
Yeah, amazing. Regardless of the data saying that there's not toxicity at 10 years, great data, we give the IVT and our own, just the 2 single amino acids, 25 grams of each, no issues there, and it's a great way to hydrate them. And he's got borderline, everything about this man is borderline. His GFR is about 45, but there's been no further deterioration.
Did you want to ask anything, Nick?
My question was about whether, what's the rationale for 4 cycles versus just giving 2 rather than 4, and keeping some in reserve. But also, I just wonder if this is where an alpha particle dotatate eventually will be where we go, as we're starting to do with PSMA.
Good point about the rationale. We don't know. I think in her she was long enough. She had such a good response the first time. We thought for 4.
Yeah.
Is it okay?
This next patient, grade 2-3 metastatic neuroendocrine tumour. He's a fascinating case. This is the primary disease, which this is the FDG down below. Ignore this focus in the thyroid. It was a Hurtle cell cancer that was dealt with separately. His primary disease is dotatate avid around the periphery of it, and within the centre of it is FDG avidity. Also some dotatate avid metastasis. Given that high grade and highly dedifferentiated disease, the patient had chemo as the first line therapy. Interestingly, the FDG avidity went down significantly, but if you look at the dotatate imaging, it's almost as though the high clone disease responded to chemotherapy and the lower clone took over, and we now have a very dotatate avid pancreas. The patient then went on to lutate therapy, and we have near normalisation of the FDG and significant regression of the pancreatic disease and of the liver metastases. And over time, since then, we've been looking at him, and he's got barely anything left in his pancreas just recently. So grade 2-3 pancreatic disease, 2014, here we are 4 years later, sequenced through chemotherapy and then to lutate, and he's had a remarkably good response.
Because they have somatostatin receptors and they respond to the lutathera. So.
And the use of the dual PET imaging has helped us select patients who've been responsive to chemotherapy, lost their discordant disease, and then they go on and have some lutate.
One question I have, and I'm struggling with patient, like let's say for example that on the NAVNIC trial, they're on chemotherapy, they're doing well, but they have dotatate avid disease. Would you stop the chemo and treat that, or would you wait until the chemo stops working? What's your...
What we have done so far is that we use the chemo as long as it's working, and then we stop it and go for the new therapies. We have not been combining chemo plus lutetium.
Do you think there's a risk of missing a window? Because in one case at least, the wait was so long that like by the time everything was organized, she lost weight, and then she, you know, like...
But that is another story. If she is going down clinically, then...
The scans were stable.
Yeah, but you had to look at the patient. You can't just look at the scan and say, but the patient is going down and dying in front of you.
No, not dying.
There's a scan.
Somewhere in the middle. It's not all.
So
in this patient who's had a good response, so what's the role of surgery?
Yes, I mean, certainly downstaging, and we've got cases which have been dowstaged to resection. I'm not sure why this one's never had surgery.
Yeah, I don't know why we haven't discussed that, but it is discussed. And we've actually got a number of series that we've actually had resected. Obviously, we're presenting these cases mainly through their imaging without all the detailed clinical information.
Probably because there was no surgeon in the
Well, that could be. No, but we would present such a case to the HPV MDT. So we would get around that.
Now, bear with me for the last case because it's a little bit more of a complex journey to a similar punchline. Metastatic pancreatic neuroendocrine tumour with adrenal and liver metastases. The primary pancreatic mass and some liver mets were resected in 2014, recurred quite quickly in the liver, had some RFA, progression further in 2015. So here we are, 2015, and we've got liver metastases with a discordant lesion in the liver. So the patient had carbotoposide to try and address this more aggressive clone. Unfortunately, the patient showed no response to that, with progression of that lesion and another, and more dotatate avid disease. So the patient, I think, went on the control next trial with lutate and CAPTEM. Interestingly enough, just looking at those two foci of FDG, so within the sea of dotatate avidity, that lesion stands alone as discordant. Similarly, this one. So we need to keep our eyes open. With lutate CAPTEM, the patient showed regression of disease, normalisation of the FDG after 2 cycles, and after 4 it looked all right. A year after the beginning of therapy, looking again, the dotatate avid disease looks okay, but this segment 2 lesion is on the march again. In behind all of this is the adrenal lesion, which is responding, but I'll get more to that in a moment. So the patient was observed, this lesion in segment 2 got bigger. Here it is on the FDG. It's clearly discordant by comparison with the dotatate imaging. The adrenal mass is also bigger FDG avid. It's got no dotatate avidity to allow us to treat with lutate again, and the patient was put onto Folfox. Just recently we've seen the patient again, and what's happened is that the FDG avid disease is still there, but it's developed a dotatate avidity in a similar pattern to the FDG. The adrenal lesion has also become markedly dotatate avid. So we now have another signal to try and treat this patient. So this patient has now got concordant disease and is going to have lutate therapy.
Bill?
Do you leave them on the Folfox?
No, I didn't in this case because he wasn't tolerating it very well. But your argument about being radiosensitizing with everything else presumably is what you're getting at. When we do second line of lutate, we tend to do it not necessarily with capecitabine. This guy's in trouble, I think. He looks well when you see him clinically, but his imaging looks horrible. Different.
But again, you look at the patient, he's feeling fine. Now, actually, this is an interesting case, and you were giving Folfox, we're jumping over the step of temozolomide and capecitabine.
He had CAPTEM.
Yeah.
He progressed on CAPTEM.
Okay.
So there's that second line Folfox. So we
Okay.
chose not to use everolimus or sunitinib because he had FDG avid disease.
Yeah.
So he's had carboetop, CAPTEM, now Folfox.
He previously had carboetopside elsewhere before he came to us.
Yeah.
I insist on the point that in some of these patients there's a window, like you can treat them. If you miss that, then like it progresses rapidly. So that's the point I was trying to make. Like they're like kind of echo 0-1, and all of a sudden they're bedridden if you don't treat them. That happens in some cases.
We've had cases like that. One in particular, our very first lutate case, who looked. He looked horrible, but we referred him as well. His liver function test went off, but he had markedly progressive FDG evidence. Within one lutate, his pain had resolved with diffuse bone disease, and he felt much better. So to your point about the window, he was actually going downhill very quickly, but was rescued very quickly with an immediate systemic therapy. So I think you'd have to consider systemic therapy in someone you're worried about.
I've just got a question. When is someone going to do a study where we look at increasing the somatostatin expression with a single dose or something of chemo in order to bring these tumours to a treatable state with PRRT?
So switching them on.
Switching them on. Or use an antagonist, sure, but I mean, isn't that an interesting question to ask?
He did it to Peter Mac.
Thank you. My comment is with regards to Mustafa's comments. I think I agree with Dr. Olberg that the clinical picture matters in these patients. If I see a patient who is rapidly deteriorating, I tend to think that that's a patient where chemotherapy is indicated. I do have a patient who I treated in 2011. His initial presentation was that of metastatic lung cancer. The pathologist had actually reported this as a poorly differentiated carcinoid. But on his PET imaging, there was a bit of discordance. So I got the liver biopsied, and it turned out he had a neuroendocrine tumor. And I asked the pathologist to look at the lung again, and he had neuroendocrine markers on his lung cancer. He ended up having carboetopside, which he responded to very well. But he progressed within about 2 months. So he changed to his second-line protocol, and he had a good response after that. Clinically, he remained quite stable, and he had a chromogranin of over 20,000. He's been on a somatostatin analog since then. Up to now, he's never had any other treatment at all. I've got another young lady I'm treating right now, presented with discordant disease. The bone disease is octreotide positive, but the soft tissue disease was FDG positive. And she has a complete response of the FDG positive disease on PET scan, and she's got residual octreotide positive disease, and she's now having PRRT. And she also had a period of stability during treatments, and clinically she looked pretty well after treatment. But often, if it's FDG positive and it's rapidly progressive and it's a very short refractory time, I would think chemotherapy is indicated rather than PRRT.
Can I just ask something about this last patient? This is a very interesting case, and you have not planned to do any biopsy from this metastasis where you have this change from FDG positivity in the middle, and now you have a concordant expression of somatostatin receptors and maybe some other interesting markers if you start to look more carefully. So I think this is a tumor I would biopsy.
That's a good point. We've actually done biopsies, but I haven't looked up his most recent situation to understand why. He was clinically deteriorating, and I guess in his particular case, we probably moved on to therapy faster than waiting. The biopsy could have been done and sent away, which we've done in previous times, but still elected to do treatment. But we would biopsy him if we feel the window of opportunity is sufficient.
But just for scientific interest.
Well, we've got a series, Shell, that Gunther Klopel is going to look at for us, which we've done image-guided biopsies, exactly similar situations such as this.
Quick question. It's a global question to every oncology or nuke med person here. Do you feel that the adrenal gland is a sanctuary site? Some of the biggest metastatic growth I've seen with breast cancers and NETs have been from adrenal mets. Quick question, there's no evidence for this, but is it a site where you would consider resecting, directing treatment differently, because other ones that for some reason seem to have this discordant growth? It's not large numbers, but I've seen it in breast. And I don't know if it's a sanctuary site.
I'll speak in my experience with lung cancer and other tumour types. So we resect it if it's an isolated oligoprogression for that reason, if it's behaving discordantly and everything else, and the patient's well and can handle it. And we've done it in oncogene-driven lung cancer, particularly with isolated metastases, where everything else has been stable. I don't know if sanctuary is the word necessarily, but it's got a rich blood supply, but perhaps that's why it often grows well. Who's over there? Oh, yeah.
Other people may know this, but I discovered this in reading around lymphoma of the adrenals, that the adrenals don't actually have a lymphocyte population or a lymphatic system within the actual cortex and medulla, so it may actually be a true immunologic sanctuary site.
Thanks for that.
Why lymphomas occur there?
Yeah. Bill, do you want to have the last comment? Did you?
I always have the last say.
I'm going to have to follow you after this one, but
Just to say that I think these cases very aptly illustrate the importance of doing combination FDG and gallium dotatate PET in patients. You don't get a good understanding of the tumour biology unless you do that. I think many groups in Australia have been coming to that view sort of independently, but it's probably time that it started getting into guidelines, because I just really think that you need to do the combination of both to understand what's going on with patients.
Thanks, Bill. The North Americans won't put in their guidelines because they can't access universally nuclear imaging. They've made that clear.
I think it will come in the ENETS guidelines in the next issue. And I think it's a growing interest in Europe to run both FDG and gallium together.
Now, I'd like to thank you all. I'd like to ask you to put your hands together to Liz Bernard for an excellent presentation.